Cannabis use disorder represents a significant and often underrecognized public health concern that affects millions of individuals worldwide, with approximately 4 million people in the United States alone meeting the criteria for this condition. Despite widespread perceptions of cannabis as a relatively harmless substance, particularly in light of increasing legalization and medical use approvals, cannabis use disorder is a legitimate medical condition that can cause substantial impairment in an individual's daily functioning, relationships, and overall quality of life. The disorder is characterized by problematic patterns of cannabis use that lead to clinically significant distress or impairment, challenging the common misconception that cannabis is non-addictive. The landscape of cannabis use has changed dramatically over the past several decades, with significant increases in both the potency of available cannabis products and the prevalence of use across different age groups. Modern cannabis products often contain much higher concentrations of tetrahydrocannabinol, or THC, the primary psychoactive compound, compared to cannabis available in previous generations. This increased potency, combined with new methods of consumption including high-concentration extracts, edibles, and vaping products, has contributed to rising rates of cannabis use disorder and more severe presentations of the condition. Understanding cannabis use disorder is crucial as society continues to navigate changing legal landscapes and evolving attitudes toward cannabis use. Neurobiological mechanisms and effects. Cannabis exerts its effects primarily through interaction with the body's endocannabinoid system, a complex network of receptors and neurotransmitters that plays crucial roles in regulating mood, memory, appetite, pain sensation, and cognitive function. The primary psychoactive component, THC, binds to cannabinoid receptors, particularly CB1 receptors, which are densely distributed throughout the brain in areas responsible for thinking, memory, pleasure, coordination, and time perception. This binding disrupts normal neurotransmitter communication and produces the characteristic effects of cannabis intoxication, including altered perception, mood changes, impaired coordination, and difficulty with thinking and problem-solving. With regular cannabis use, the brain undergoes significant adaptations in an attempt to maintain normal function despite repeated exposure to THC. The endocannabinoid system becomes downregulated, meaning the brain produces fewer natural endocannabinoids and reduces the number and sensitivity of cannabinoid receptors. This neuroadaptation leads to tolerance, where users need increasingly larger amounts of cannabis to achieve the same effects they once experienced with smaller quantities. The brain essentially becomes dependent on external cannabinoids to maintain what it perceives as normal functioning. Clinical presentation and diagnostic criteria. Cannabis use disorder is diagnosed based on specific criteria that evaluate patterns of cannabis use leading to significant impairment or distress in an individual's life. The diagnostic framework focuses on 4 main areas of dysfunction: impaired control over cannabis use, social impairment resulting from use, risky use patterns, and pharmacological effects, including tolerance and withdrawal. The severity of cannabis use disorder is classified as mild, moderate, or severe based on the number of diagnostic criteria met, allowing for a more nuanced understanding of the condition's impact on different individuals. Impaired control manifests in various ways that often surprise individuals who believed they could easily stop using cannabis whenever they chose. Common signs include using cannabis in larger amounts or for longer periods than intended, persistent desire or unsuccessful efforts to cut down or control use, spending considerable time obtaining cannabis or recovering from its effects, and experiencing strong cravings or urges to use cannabis. Many individuals with cannabis use disorder describe feeling as though their cannabis use has become automatic or habitual, occurring even when they don't particularly want to use or when it interferes with their goals and responsibilities. Physical and psychological consequences. The physical health consequences of cannabis use disorder are often underestimated but can be significant, particularly with long-term, heavy use. Respiratory problems are among the most common physical effects, especially for individuals who smoke cannabis. Regular cannabis smoking can lead to chronic bronchitis, respiratory infections, and a persistent cough, with increased phlegm production. While the relationship between cannabis smoking and lung cancer remains under investigation, the combustion of any plant material produces carcinogens and toxic compounds that can damage lung tissue over time. Cardiovascular effects of cannabis use include increased heart rate and blood pressure immediately following use, which can be particularly concerning for individuals with existing heart conditions. Some studies have suggested an association between cannabis use and increased risk of heart attack, particularly in the hours immediately following use. Cannabis use can also affect coordination and motor skills, increasing the risk of accidents and injuries, particularly when driving or operating machinery. The impairment from cannabis can last much longer than users realize, with some effects on coordination and cognitive function persisting for hours after the subjective high is worn off. The psychological and cognitive consequences of cannabis use disorder can be particularly debilitating and long-lasting. Chronic cannabis use is associated with increased rates of anxiety and depression, though the relationship is complex and bidirectional. While some individuals initially use cannabis to manage anxiety or mood symptoms, regular use often exacerbates these conditions over time. Cannabis use disorder frequently co-occurs with other mental health conditions, including attention deficit hyperactivity disorder, bipolar disorder, and personality disorders, complicating both diagnosis and treatment. Risk factors and vulnerability. The development of cannabis use disorder results from a complex interplay of genetic, environmental, psychological, and social factors that vary significantly among individuals. Genetic factors play a substantial role, with family history of substance use disorders, including cannabis use disorder, significantly increasing an individual's risk. Twin studies suggest that genetic factors account for approximately 50 to 70% of the risk for developing cannabis use disorder, indicating a strong hereditary component. Specific genetic variations affect how individuals metabolize cannabinoids, their sensitivity to cannabis effects, and their vulnerability to developing dependence. Environmental factors during childhood and adolescence significantly influence cannabis use disorder risk. Early exposure to cannabis, particularly before age 15, substantially increases the likelihood of developing cannabis use disorder later in life. Adverse childhood experiences, including trauma, abuse, neglect, and family dysfunction, also increase risk, as individuals may turn to cannabis as a coping mechanism for emotional distress. Peer influence plays a particularly important role during adolescence, with social acceptance of cannabis use and easy availability contributing to initiation and continued use. Psychological risk factors include certain personality traits such as impulsivity, sensation-seeking, and difficulty tolerating distress or boredom. Mental health conditions, particularly attention deficit hyperactivity disorder, conduct disorder, depression, and anxiety disorders, significantly increase the risk of developing cannabis use disorder. Many individuals with these conditions initially use cannabis for self-medication purposes, but this often leads to a pattern of dependence as the underlying mental health issues remain untreated. The presence of other substance use disorders also increases the risk of developing cannabis use disorder, as individuals with addiction vulnerabilities often struggle with multiple substances. Treatment approaches and recovery. Treatment for cannabis use disorder has evolved significantly as our understanding of the condition has improved, moving from a largely overlooked problem to recognition as a legitimate disorder requiring specialized intervention approaches. Unlike some other substance use disorders, there are currently no FDA-approved medications specifically for treating cannabis use disorder, making behavioral interventions the primary treatment modality. However, research into potential medications is ongoing, with some promising early results for compounds that target the endocannabinoid system or address withdrawal symptoms. Behavioral therapies form the foundation of evidence-based treatment for cannabis use disorder, with several approaches showing significant effectiveness in clinical trials. Cognitive behavioral therapy helps individuals identify triggers for cannabis use, develop alternative coping strategies, and change thought patterns that contribute to continued use. This approach is particularly effective in helping individuals recognize and modify the automatic thoughts and behaviors that lead to cannabis use. Motivational enhancement therapy, which incorporates principles of motivational interviewing, helps individuals resolve ambivalence about changing their cannabis use and builds internal motivation for recovery. Contingency management has shown particular promise in treating cannabis use disorder, using positive reinforcement to encourage abstinence and engagement in treatment. This approach provides tangible rewards for achieving treatment goals, such as clean drug tests or attendance at therapy sessions. The immediate reinforcement helps counteract the brain changes associated with cannabis use disorder that make it difficult for individuals to focus on long-term benefits of abstinence. Family-based interventions can be crucial, particularly for adolescents and young adults, as family support and involvement significantly improve treatment outcomes. Cannabis withdrawal, while often dismissed as mild or non-existent, can be a significant barrier to recovery for many individuals with cannabis use disorder. Withdrawal symptoms typically begin within 24 to 48 hours of stopping cannabis use and can include irritability, anxiety, sleep disturbances, decreased appetite, restlessness, and physical discomfort. These symptoms can persist for several weeks and often contribute to relapse if not properly managed. While medications are not routinely used for cannabis withdrawal, some individuals may benefit from short-term treatment of specific symptoms, such as sleep aids for insomnia or anti-anxiety medications for severe anxiety. The recovery process from cannabis use disorder often involves addressing the underlying issues that contributed to problematic cannabis use, such as mental health conditions, trauma, or difficulty coping with stress. Many individuals find that they need to develop entirely new coping strategies and social networks, as their cannabis use may have become deeply integrated into their daily routines and social activities. Support groups, while less common for cannabis use disorder than for other substances, can provide valuable peer support and practical strategies for maintaining abstinence.